over to our first speaker. So we are opening with David Gordon, who is a Professor of Social Justice and the Director of the Bristol Poverty Institute here at the University of Bristol. He's written and edited over 200 books, papers and reports on poverty, inequality and social exclusion, social justice and social policy, and has advised governments, international agencies and task forces across the globe on multidimensional poverty issues. In 2019, he was elected a Fellow of the British Academy in recognition of his exemplary work in the field of social science research. His presentation will introduce his research on which people are at greatest risk of contracting a COVID-19 infection in Africa due to their living circumstances, which, mainly as a result of poverty, make them highly vulnerable. So over to you, Professor Gordon.
Thank you very much, and thank you everybody for joining this webinar this afternoon. I'm going to talk about vulnerability to COVID-19 infections in Africa and the living circumstances that make some people much more vulnerable to having an infection, and if they get an infection, having a severe infection. I'm going to draw on the work of a large number of my colleagues, in particular an analysis of survey microdata from over 50 countries, which collected information on over 3.2 million people. These colleagues are in several African countries, particularly Ethiopia, Uganda and South Africa, but also colleagues in North America and in Asia, as well as in Europe. I'm going to share my screen and show a few slides. Okay. Okay, so poverty has always been a contributing factor to pandemics. Even in the archaeological record, what we find is that even in pre-industrial society, those at greatest risk during pandemics were often those who were most marginalized or already poor. Can everyone see my slides? Thanks. Depending on how long this pandemic will go on for and how bad an effect it will have on the economy, there are a range of estimates which show that it's likely to increase the amount of severe poverty, particularly in Africa. Somewhere between tens of millions of people, and if it goes on for a long time and has a big economic consequences, maybe even hundreds of millions of people will be driven into the most severest poverty. Recent surveys in Africa, one of small businesses, 2,500 small businesses across 8 countries, which are receiving microfinance loans, showed that 92% of these businesses had suffered falls in their income, which affects their ability to repay the loans. So the pandemic is likely to have a dramatic consequence. What we know from previous epidemics that have happened, not just in Africa, but also in Asia during the 21st century, is that they have a consistent effect on increasing the amount of inequality. The rich tend to get richer and the poor tend to get poorer in epidemics and pandemics. So these graphs show the number of years after the pandemic, and what you can see is that during the pandemic or epidemic, the rich tend to see a small growth in their income, and over a 5-year period, their relative incomes tend to increase relative to the rest of the population, whereas for those at the bottom of society, the poorest people, their incomes tend to fall, not just during the epidemic or pandemic, but also over the preceding the subsequent 5 years. And this has been happened with SARS, H1N1, MERS, Ebola and Zika. And these, of course, had less devastating economic effect than the current pandemic is. So we expect to see this pattern, but much more so. Now, at the moment, there are no effective treatments against the pandemic. There are some treatments like steroid treatments which will reduce the number of people who die. There are some other treatments which may make the mild infection end quicker, but by and large at the moment our only defense against the pandemic are what are called non-pharmacological interventions. Basically social distancing, quarantining, wearing masks, the kind of things that you all know about from all the public health advice you've been getting. There is great hope that there'll be a vaccination available sometime next year, but at the moment our only protection against the pandemic are these non-pharmacological interventions. So what's happened in Africa? Well, the first case of COVID-19 infection was detected in Africa on the 14th of February. Unfortunately, the African Union quickly adopted a continental-wide strategy, which was published in early March. So African institutions and the African CDC responded very quickly, as did most African governments. They responded rapidly to the growing pandemic threat by enforcing quarantines, lockdown procedures, border controls, and providing broad public health information. However, there are great concerns, and certainly were at the beginning of the pandemic, that there were likely to be a devastating impact of the pandemic in Africa, because 56% of the urban population is concentrated in overcrowded, poorly serviced slum dwellings. Only 34% of households have access to hand washing facilities, and 71% of Africans' workforce is informally employed, and most can't work from home. That was the initial analysis of the UN Economic Commission for Africa. European-style lockdown policies, like the one that's currently happening in the UK, can be counterproductive in most African countries as a disease control measure, particularly if they result in a loss of livelihood and a consequent reverse migration of impoverished urban dwellers back to rural villages. This potentially spreads the disease more rapidly from the urban centres to the countryside and can also cause conflict in rural areas. So you can't take policies which have been advocated in, say, Europe or North America and transplant them to Africa. Now, some African countries are extremely poor. So here's an example of some recent research that I've done with colleagues on child poverty in Uganda. In Uganda, 3 out of 4 children don't have their own bed. 1 in 2 children in Africa don't get 3 meals a day, and hunger and malnutrition are widespread. 1 in 3 parents can't afford to take their children to health facilities or get the medicines they require when they're sick. 3 out of 10 children don't have soap and toiletries to keep themselves clean. These are extremely high levels of poverty compared to, say, many European countries. However, this has not stopped African governments and African people from fighting the pandemic effectively. The Lancet held a global commission on COVID-19 and issued a statement in September to coincide with the 75th session of the United Nations General Assembly. They argued that 19 places where had the pandemic had been effective in suppressing that pandemic. 3 of those countries were in Africa: Uganda, Togo, and Rwanda. And in particular, Uganda achieved the best results in Africa. These are not by any means the richest or countries in the world or the countries with the best health systems. For example, Uganda has a lot of experience in dealing with life-threatening infection diseases. It has a public health system which effectively dealt with outbreaks of Ebola virus disease in 2000, 2007, 2011, 2012, and 2019. And it had a strong system in place. It also implemented anti-infection measures 4 days before the first case arrived, and by the end of August, Uganda had only had 2,750 cases and 28 deaths. This contrasts with the UK, which, although it has a slightly larger population, had over 40,000 deaths and getting on for 1 million cases by the end of August. Now, some of the reason that African countries have done well is that they have a relatively young population, which is often relatively healthy. So this is an analysis from the Lancet. The light green bars show those at risk of, the percentage of the population at risk of a severe infection because of underlying health conditions such as diabetes or high blood pressure. And the dark green bars show those who are likely to need a hospitalization if they catch the infection. And as you can see, countries like Togo, which managed effectively through public health measures to suppress the virus, even though they had a relatively high proportion of their population, 50%, 15% at high risk of getting a severe COVID infection. Good policies, particularly with a population that's used to fighting infectious disease, can have very positive outcomes, much better than has been achieved in Europe and North America. So in order to look at vulnerability, we need to look at who is likely to get COVID-19 infections because of their living circumstances, and who is likely to get a severe infection because of their living circumstances. Those likely to get the infections are those who have lots of other contacts with people and who have large households, so they can spread the disease within their households. And we break down the reproductive number of the virus, R0, look at the chances of the infection spreading within the household and within the community. And we can look at a number of circumstances, the way people live, which are more likely to put them at risk of getting the infection. So within the household, people who live in large households, 6 or more, or overcrowded, where there are 3 or more people sleeping in one room, or whether they're older people over 60 living with 3 or more younger people, or where there's someone in the household who is obese, a BMI over 30, or where there's no soap or detergent or no refrigerator, so people have to go out every day to buy food or get food. These are circumstances that are more likely to spread the disease within the household if some household member becomes infected. Where people have to share the toilet with another household, or don't have a toilet facility and therefore have to use the fields or a forest or the street, where they need to go and collect firewood or buy firewood in order to cook in their own home, or where they don't have a water source in their own home and have to share it with a neighbour or with the community, they're more likely to come into contact with people outside their household and thereby also spread the disease if they have it or catch the disease from other people. So it's these kinds of living conditions and circumstances which are highly likely to make people at greater risk of COVID-19 infection in low and middle income countries in Africa. When we look at the data, we find that there are some parts of Africa with very high likelihoods where more than 80 to 90% of the population have one or more of these vulnerability indicators. The bright areas on this map, which has been produced by my colleague Professor Rich Harris, show areas with high levels of vulnerability because of living circumstances. Similarly, if we look at these measures individually, these are small area estimates. This is preliminary analysis we're at in the rest of the countries. You can see that there are very high numbers of people in many countries. These are the yellow areas on the map, which need to leave their house every day to get firewood or fuel, or regularly to get firewood or fuel, or to get food because they have no refrigerations. There are large numbers of households which need to go and collect water, or don't have their own sanitation facilities, or don't have access to soap. There are also large households, particularly in urban areas of Africa, less so overcrowded and older people living with younger people compared to, say, some richer countries. So let me come to some conclusions. The COVID pandemic is the most significant global disaster since the Second World War. Its effects are likely to be profound and long-lasting. And some historians argued that future historians will divide the past 100 years into two periods, BC and AC, before and after Corona. Complying with social distancing policies is difficult, where people need to leave their homes to satisfy their basic needs, to get food, collect water, to use sanitation facilities, to collect or buy fuel. For example, if you take one country in Chad, more than 90% of the population live in households which have no refrigerator, and 90% need to collect or buy firewood to cook. Over 80% need to collect water from public sources or share toilets with their neighbours, and 70% live in households with 6 or more people. Under these circumstances, complying with social distancing is very difficult. To enable vulnerable households to comply with quarantine and requirements, governments need to either provide poor households with food or the money they need to buy the food, either through social protection or social security measures. Poor households may also need soap, water and cleaning materials in order to protect themselves. Local authorities can help facilitate queuing with social distancing measures, standing more than 1 metre apart at public water points and public toilets and latrine facilities. They can also prevent mass gatherings, or try to, and encourage the public to wear masks and face coverings. Governments also crucially need to continue to invest in the health services. It's estimated that the current levels of disruption to the health services caused by the COVID-19 pandemic may result in a 10% increase in HIV deaths, a 20% increase in deaths from TB, and a 36% increase in deaths from malaria over the next 5 years, compared with the number we would expect if there had been no pandemic had occurred. Similarly, over 100 million children in 37 countries may not be able to receive their measles vaccination, which will can lead to a massive increase in the number of children dying of measles. So there's a danger in Africa that even if governments and the public manage to protect themselves from COVID-19, if there's huge disruption to the health services, deaths from many other causes may increase, and therefore the COVID-19 pandemic may not be the only cause of increased deaths. I'll leave it there, so there's time for questioning. Thank you very much.
Thank you very much, David. That was really, really interesting, and please do type questions in the Q&A box at the bottom. We've got one waiting already, which is, I'm afraid I'm not sure on their name, but it's come through as they said they're a non-academic listener, and their comment is that it says Civic-19 pandemic, but I assume that means COVID-19 pandemic, has exhibited that governments, organisations, etc. were not ready to confront this despite previous crises. And why do you believe that was the case, or suspect that was the case?
Well, that's been the case because there hasn't been investment in the health services. But as I tried to make clear in my talk, some governments were ready, and the governments that were ready, in part because they have been fighting Ebola and other pandemics over the past 20 years, and they had systems in place that worked, that they managed to effectively suppress the virus. They've had as good or better outcomes than countries like New Zealand, which also managed to suppress the virus, and far better outcomes than, say, the UK or France or the USA, which are much richer. So preparation is key. Where countries have been prepared, where they've talked to the population, where the public health information system is in good, and the population have had the information they needed, where the population, they've supported traditional methods of social isolating of people who've become infected, their outcomes have been excellent. Where that hasn't happened, where there's not trust in government, where the population don't believe the information they've been told and misinformation has spread, where the health service has not been able to rise to the challenge of COVID-19, that's been devastating. And the indirect consequences, unfortunately, have been also that people have lost their livelihoods. Some of the increases in poverty will have long-term health consequences. Governments need to not just rise to the challenge of tackling the health crisis, they need to also rise to the challenge of making sure that there's not a mass increase in poverty.
Great, thank you very much, David, for that really comprehensive answer. Hopefully that's dealt with, well, not dealt with it, but given some insights into why that might have been the case. We've got a question from Kitty Rowland, who says, thank you very much for the interesting presentation. Can you elaborate on the urban versus rural dynamic in terms of vulnerability to COVID? For example, lockdown measures were often limited to cities, and many of the urban cash transfers in response to COVID in Africa were particularly focused on urban areas. So should we focus more on those urban areas?
Thanks, Katie. That's a really important question. The answer to that is both yes and no. So if you look at the COVID vulnerability indicators, which I showed, subdivided by urban, rural, of course, the need to leave your home every day to go make your basic needs is often much higher in the rural areas than in the urban areas. It affects a higher percentage of the population. The rural areas, by contrast, often have more space and more traditional methods of isolating people who may become infected in facilities at the edge of the village. In urban areas, you often have the problems of overcrowding and high density populations where the pandemic can spread much more rapidly and where people may be sharing water facilities and toilet facilities in much greater numbers. So you probably need different policies aimed at urban and rural areas. And one of the reasons we've been doing these small area estimates is to highlight what particular vulnerabilities are happening in what particular areas. So in rural areas, you may need to distribute soap, but in urban areas, you may need to set up isolation facilities and so that people can be separated if they get infected with the COVID-19 infections. And you may need to have, of course, public health information in both areas is crucial.
Great. So we're pretty much out of time for David's Q&A, but just one final comment that came in from Francesca, which is Rwanda is one developing country with limited resources and similar or little better indicators than those presented on Chad, but yet they managed to contain COVID-19. So it's more of a comment than a question, but I didn't know if you wanted to briefly respond to that before we move.
Yes, I'd like with Uganda, Rwandan government and Rwanda local government responded very rapidly. The population trusted the information that was being given and they implemented a large number, I think almost 13 different public health measures which help protect the population against the spread of the pandemic, and they successfully suppressed the pandemic.